And you make a recommendation to the board. It's not like you will be making a decision. You'll just be making a recommendation.
Correct.
So it's up to you, and as to how long you want to wait to give others to join, or if you think you need more participation and want to try to reschedule.
I think we could, Dr. Annalini, is it okay if we just continue with, I think it's just you and I from the board?
Yeah, let's just put some things together. And I mean, I think that since we're a subgroup of the board and we're designated, as healthcare providers to make a recommendation to the board itself, I don't see why we shouldn't be able to go ahead and just talk amongst ourselves.
Sounds good. I agree. And so Crystal, also just again, for procedural purposes, it doesn't sound like the public have requested the link for this, so there would not be opportunity for public to make comment.
No, they could still make comment if someone joins.
Okay. And I know in the previous meeting, so if somebody does want to make public comments, the recommendation was to limit it to 1 minute or less. And I'm assuming then that I would need to get Dr. Antolini's agreement in that to continue that practice.
Yes, if that's what you both agree.
Okay. Is that acceptable to you, Dr. Antolini?
That's fine with me.
Thank you. So shall it be? And are there any other procedural issues then, Crystal, that we need to address before we move on to the substance?
No, I don't think so. Just let me introduce the meeting. Dr. Antolini, I'm Crystal Lowe. I'm the Assistant Office Director for the Office of Medical Cannabis. I know you all are accustomed to Jason Frame, the director, for being here, and he wasn't able to be here this evening. So this is a meeting of the Advisory Board's Health and Medical Work Group, and you are here to discuss the Board of Pharmacy's, is it CSAP?
Yes.
Okay.
Yeah, CSAP, CSAPP.
Okay. All right. Well, I will turn it over to you.
All right. Thank you. Pleased to have Dr. Mike Goff, the director of the Board of West Virginia Board of Pharmacy, with us to try to answer some of the questions that the larger advisory committee is trying to wrestle with regarding what it would mean to be able to add dispensed cannabis to the West Virginia CSAP. And so, Dr. Goff, thank you so much for taking the time to be present with us this evening. So would it be possible maybe to start with what you see as the state of affairs regarding how this is being done in other states that you are aware of, and then what it would mean for us to go forward to try to make this happen in West Virginia?
Yeah, I can give a general overview. I spoke to my vendor earlier just about how this would potentially work. And I'd like to start off by saying I'm not a doctor. I'm just a guy. So.
Thank you. But
I didn't want get any medical opinions confused with what I might be saying.
Got it.
But generally, CSAP is our vendors, what they call their product. It's referred to in the state as the Controlled Substance Monitoring Programs, how it's in code, and that's CSMP. Generally, they're prescription monitoring programs. PMPs or prescription drug monitoring programs. The acronyms vary, but CSAP is our vendor's brand name. But as you all know, basically it reports, or the pharmacies report dispensed controlled substances to the monitoring program when a prescription is filled in West Virginia to a patient for any schedules 2 through 5, and things that are mail order from other states to a patient here. You know, these medical cannabis products don't fall in any of those categories really currently. And when those prescriptions are reported, generally it's the patient's information, the prescriber information, his DEA registration and related info, the pharmacy's dispenser DEA registration and related information, and the product information, which is transmitted via the drugs, National Drug Code number, the NDC number. They don't report that it's a 5 milligram, 325 milligram, hydrocodone acetaminophen report. They just send the NDC code, and our system interprets that NDC code and inputs the corresponding data into the reporting system. Similarly with DEA registrations, it transmits the prescriber's DEA. Our system interprets the prescriber or the pharmacy's name, address, and all the related information that goes with that DEA. So in the scenario of a non-NDC coded product, which these would be, there's no database that our system has available, or our vendor has available to translate, numbers 1, 2, 3, 4, 5 is this drug product. So that's the first issue, is coming up with product names, categories, ways to report the various medical cannabis products. That's the first thing that my vendor would have to come up with, is some way to come up with a way to translate the different, and I don't know how many products there are, but I guess they would kind of categorize, whether it's a tincture, an oil, or in other states it might be an edible kind of thing, come up with the amounts, the types of products, kind of something that would be translate from a pill with so many milligrams of a drug to whatever these non-typical products are. Usually they're tablets, capsules, liquids that we see normally. This would be a different variation of those sorts of products. The dispensary itself, who dispenses the products or hands out the medical cannabis, would have to have some sort of a unique identifier to identify the kind of a corresponding to a pharmacy. They have their DEA registration. We have to have some way of identifying the various approved dispensaries who's handing out the medical cannabis products. If these are dispensed pursuant to some sort of medical order, you would need some sort of way. If it's a regular physician and has a DEA registration, I don't know if that would be available for those kind of things, or if there are other people who would dispense the products. I'm not familiar with all those, but you just basically have a way of identifying the product, the person who's handing out the product, and the person or the facility who hands it out, and the person who's ordering it to be dispensed. The patient information would all be consistent. It'd be the same as a regular prescription. I assume you have some sort of an ID process, verify the ID. But the way that would work would be how the details would be figured out with our vendor, because currently we have a function where non-pharmacies can report information to the system. The health departments were reporting information related to naloxone dispensings at one point. Veterinarians report to the system, or used to report to our system in a non-standard way. But they have a piece of software that can be assigned to a entity to dispense and report information to our system without being an actual pharmacy. So some of the things that would be available to do this reporting exist. The things that we'd really need to figure out is how to identify the various medical cannabis products, as well as the dispensaries who are dispensing those products. Is that a general enough description?
That gives me a greater, at least it gives me a greater understanding of how this sort of functions in general.
I think a lot of that will be outside of the scope of what we're trying to recommend, though.
Yeah, I'm wondering if we simplified it to where it's just the broad category of cannabis and not have it necessarily indicate, for instance, the type or the amount or anything, just that it was essentially a binary mechanism, cannabis dispensed on this date. I'm wondering if that would make it simpler, and I think that would get at the interests that the physicians in the community would have, whether to know whether or not their patients have been dispensed medical cannabis.
I mean, from my standpoint, I think that would be a first step in being helpful. I'm a family practice doc. I've got people in there that are, they qualify at times for opioids, and so part of the agreement that we have in the office is that they're not using any other, quote unquote illicit substances or any non-prescribed medications. I wonder how the medicinal use of cannabis is going to affect that contract, and I'm sure you're pretty familiar with what that entails, Dr. Berry. And so it would be useful in the greater context of things. I can access that information and see where they've been prescribed at, but I don't see why that would necessarily be any different than doing a drug test and finding that on a drug test either. I mean, there's a lot to this that I'm not even sure we're able to impact. Providers aren't even dispensing it. So that kind of information that we were discussing as far as the Board of Pharmacy, that's not going to be tied to any one provider. But I think that, like you said, a binary way to determine if they've been dispensed cannabis or not that would be, I suppose, of
We lost you there, Dr. Angelini. Looks like he was logged off. Hopefully he can get back logged on here in a minute. Mike, are you still there? Well, and it looks like Mike is having audio difficulties too. Mike, are you back with us? Mike, can you hear us?
Can you hear me now?
Yes, we can hear you now. Thank you.
You had to call back in for some reason. I lost audio on my computer and my phone.
Oh no, yeah, we lost Dr. Angelini too in mid-sentence.
Yeah, I still don't have it on my computer, but I can hear you now.
Okay. So Mike, if we were going to go in this direction, would it be easier if it was just more of a binary issue where we could say, yes, this person was dispensed, and so at least a physician could have a greater knowledge about what is being dispensed to a patient?
Yeah, that would be much simpler. And just if they had a dispensed product, and maybe in that you have some sort of notation that products could include, some list of things, maybe without any. It wouldn't matter who gave it out or who ordered it. That wouldn't be something that they wouldn't include in the information.
Right, and I believe the issue was because there would be even more tangible value for a physician who is treating a patient to know what physician had approved this, or at least who had certified for the product, so that if there were some concerns that the regular physician had regarding this particular patient's use of cannabis, that they could contact the certifying physician and talk through their concerns and deal with it that way. But that runs the risk of putting, if the name is attached to the physician on the Board of Pharmacy Controlled Substances site, then that could get into issues regarding prescribing and federal classification as a Schedule I, et cetera, et cetera, et cetera. But I do think that would be a valuable, if there's another way to do that, I think that would be of value.
Well, and say I'm not, you'd think that if I were a physician and there was a presentation in a patient's report that they were on cannabis without any specifics of what it was or who it was or for what reason, that would, I mean, that's, you think they'd want to ask somebody, I guess, unless there was
Right.
some general acceptance that, because it would be simpler. Someone at the point of dispensing the products would be when the information's reported to us, however that happens. I mean, the dispensary would have some sort of a access for limited amounts of reporting, but what's in that report would be, the question. I mean, if just the fact that they yes or no, they are just a check mark basically that they had marijuana, because that's kind of what we do now. If a patient has an overdose, for example, a non-fatal overdose, and we get that report, when someone runs that patient, there's just a header at the top that says, hey, on this date in the previous year had an overdose on this date in this county.
Right.
Just that simple information. There's no specifics of who the reporting agency was or anything. It's just we do some vetting of the reports from the whether it's an ambulance service or hospital emergency room, and if it meets the criteria to be a non-fatal overdose, it's put in the system so that it shows up if someone runs the report.
Right. And so I do think that at a minimum, that would offer some value to physicians who are, trying to, figure out what is happening with a particular patient, what are they being dispensed, and that would help them regarding, maybe they would choose to not prescribe a certain medication if somebody was on medical cannabis, for instance, for drug-drug interaction reasons, et cetera. And so I think that could be of value. So, Mike, to kind of summarize what I'm hearing right now, it would be simpler than if we just made it a yes or no thing, the way the current overdose report works.
Right. The difference is that the overdose report, we get the overdose reports, from one source, from the state health folks to my epidemiologist. They organize the data in the proper format and report to my vendor. There's only one point of reporting, where
Right.
the difference would be there'd be multiple dispensaries doing this reporting. And if all they had to report is the patient's information and the date that it was dispensed, I mean, that would basically, and it's a marijuana medical cannabis product, it would be limited information. So that would be it would be a simpler process.
Right.
And I don't know if there's if there were categories or strengths. I don't know all the different things. I mean, if they were at the low, the least THC containing medical cannabis product compared to the highest, I don't know if there's, a way to scale those, where if they were getting one, the doctor may not be concerned at all versus another one. I mean, those kind of considerations I have no way of knowing, but just the
Sure.
fact that if they knew they had cannabis at all would be sufficient to make a call. That would be up to the medical folks, I guess, to see how useful that would be.
Got it. Okay.
I think more of it, the way things are done now, and this, I understand this is a completely different product, and I didn't realize that it's just a yes or no would be a way simpler than the way we were thinking about it.
So, right. So, I mean, we weren't necessarily having that discussion brought into the previous discussions, or that issue, I should say, brought into the previous discussions. That's just something that I'm thinking about right now as I hear you talk regarding the various complications about that. So that could be, all I'm saying is that could be one strategy, is to simplify it as much as possible, to just make it, yes, cannabis was dispensed, or, obviously no, if it's not on there.
Right. Well, it wouldn't be, nothing would show up otherwise.
Exactly.
It'd just be a box show up in the report.
Right. So, Mike, if the board decided to make the recommendation to try to go forward with this, what would the next steps be, and what would be required for that to happen from a functional standpoint, not necessarily from a legal standpoint or other standpoint?
From a legislative
Yeah.
standpoint.
Mhm.
And normally, if the legislature enacts, like they passed the law to require reporting of Schedule 5 products a few years back, and say it was passed regular session in the March, or it's effective June, July kind of thing. Well, the vendor can make that stuff happen. That part's pretty easy. It's fairly automatic. It's getting the actual reporting done. Like in the
Yes.
Schedule 5 scenario, the pharmacies are the ones that's reporting it. My guys don't have to do a lot. They receive the data, and they just have to, present the data like they do every other drug product. So it was pretty easy on the vendor end in that scenario. The message you need to get out to the people who are reporting the data. In that example, the pharmacies have to know now that they have to report Schedule 5 stuff to West Virginia. Usually
Right.
That's a fairly simple thing. So on my end, I don't think that would be difficult. We'd have to figure out it's the reporting to us that would be, the dispensaries would have to be educated and provided these access points to my data sets, or to my data system, where they could report, on August 24th, we dispensed to these 10 patients. Here's their
Right.
names, and here's the information, whatever amount of information, because we have to put that in our system so that if somebody queries that patient down the road, that data shows up. Because you might run a person and they don't have any other prescriptions in their history except for cannabis.
Right.
So it has to be able to be, included in our regular data pertaining to each patient. So the way we do that now with the overdoses is fairly straightforward. And like any other data, you have issues like if someone's named John Smith, there's going to be multiple people with that name. So you have that patient matching, and in that reporting by the dispensaries, it would not just be the patient's name, date of birth, it'd be their addresses and other information that we use for patient matching normally. The other issue we have, and it's also with the overdose reporting, is this data is only presented when you log into my system. Like if you have a username and password for the West Virginia monitoring program, you log in and you pull this data out when you request the patient. Most doctors and pharmacists nowadays use their pharmacy software or their electronic health records to access that data.
Yes,
So
I see.
it's an automated process. It goes through a national hub, data sharing hub, where this data actually flows. In those instances where they're accessing this through integration, I don't know that there's a way that this kind of data can be included. I mean, that would be a different question I'd have to check on.
Oh, that's interesting. So what you're saying is that if I were to log in to my electronic medical health record, for instance, Epic is what we use here.
Right.
And were to access the CSAP report, that if I logged in that way, I wouldn't necessarily be able to show this type of information. Whereas if I logged in independently, directly to the CSAP, to the West Virginia Board of Pharmacy, then it would?
Correct.
Oh.
And I don't know that it can't be, included. I know the overdose data is not currently.
Okay, I did not know that.
It's a separate piece of information that's it's not included in the regular information fields that we currently, and that's something that they're always looking to expand the data that's sent, but the data that's shared state to state through these processes, even if you're in West Virginia, the data request goes to Kentucky and back to West Virginia. Even it's not completely in state. The data that we share the data through for these integrations is a separate connection. So those separate connections have specific data fields that are required, and these are outside those normal standardized reporting data fields. So that's something we'd have to look in to see whether that can be included in, at some point in the integration process. I don't know that it is now. I'm pretty sure that it isn't currently, or there's no way to do it at this time. That would be another thing we'd have to look into and work out. I know reporting it when you log in direct to me is pretty easy.
Right.
That can be made visible. But more and more folks are going to integration. It sounds like you're aware.
Yeah. Yeah. So, that makes me think of another issue that was raised previously by the full advisory board, at least a member, if I recall, is if dispensaries were required to put this information into the system, does that mean that by necessity that the dispensary would have access to the controlled substance record of a particular patient?
That was my concern when this first was brought up, is I wouldn't be in favor of that. And
Right.
These can be one-way reporting. They can report to us, but then not be provided any access to the patient data. There's like the scenario where the health departments that were reporting Narcan dispensings at one point. That was a one-way. They had no separate access to view, to query patient data.
Got it. Was Dr. Annalini able to get back on?
Yeah, I'm back. I'm sorry.
Oh, that's okay. I'm not sure how much you heard of the previous discussion, but please feel free to add your input or thoughts and considerations.
I'm not even sure how much of that you got. It just kind of got staticky, and I didn't hear any feedback, and so I called back in. But the long and the short of it is, I use Athena at our F2HC, and he's correct about, like, we don't ever get into CSAP individually anymore. We use our
Right.
EMR to see that. And so I'm not, back to my previous point, I guess it's of some clinical utility. If yes or no, are they using cannabis or not? Most of the, all the controlled substances, we would do a drug test prior to anyway.
Yeah.
To be able to see that. But I guess it's an entirely different thing if we know it's dispensed and we're looking at other medications that could possibly interact. But the long and the short of it is, as long as I'm able to log in to my EMR and see if yes or no it's been dispensed to them, I suppose that would be sufficient enough at this point to make a recommendation about that. But much more than that, it sounds like it's going to be prohibitive as far as the logistics of it.
Yeah, it certainly would. It certainly sounds like it would be more complicated.
Right.
They do this in Ohio currently, and I'll check with them to see if. I know that we're not seeing if one of our folks here through integration queries Ohio. I've never heard of that being included, but I'll check with them and see if they have any intentions of addressing the medical cannabis there,
So,
and
Mike,
how they're accomplishing it.
So Mike, do you know how it shows up on the report then in Ohio?
No, like I say, if they log in directly to the Ohio to ORS, it probably shows up similar to what we do. I don't know if they spell out what kind of product it is or if they have the dispensary name. I'll have to check on that to see how that works, or if it's limited to logging into their ORS system and not if it's not included in the integration process. But I'll have to check with them to see how it's accomplished in that state.
Okay. Is there anything else that we haven't considered that you believe is relevant, Mike?
Not that I can think of right now.
Okay. How about you, Dr. Anthony?
I'm still trying to figure out. Well, as far as the Board of Pharmacy goes, no, I don't have anything else that's of any value to the conversation at this point. I'm more learning and listening and trying to figure out how I would use what we're talking about in a clinical context. And I think we've gotten to that point at least.
Okay. Well, I suppose then at this point, unless there is any further discussion, Dr. Annalini, are you good with us closing the meeting?
Yeah, at this point, you're the head of the subcommittee, right? The subgroup?
Correct.
I might jot down a few bullet points and email them to you at this point, since I'm new to this group, that I was thinking in the larger meeting that we really didn't address, as far as issues related to federally qualified health centers and their role in this, and a few other points. So I'm probably going to craft an email and send it to you, but for purposes of right now, we're good.
Great, thank you for that. All right, well, meeting adjourned. Thank you, everybody, for your attendance on a warm summer evening.
Yeah, I got it.
Thanks a lot.
Crystal, is there anything else needed from your end?
No, so you are not putting forth any recommendation to the board at this time, right?
Correct. We're not putting forth any recommendation. What we were able to do tonight was at least learn a little bit more about what the system would look like and what some of the system needs would be. And I think at this point, it's trying to gather some more information. For instance, what is Ohio doing, and just go from there.
Okay,
What do you want?
that sounds good.
All right. Thank you, everybody.
Thank you.
Have a good evening.
Have a good night.
Good evening. Bye.
Thank you.